measures.
Okay.
Medusmita? Medusmita, where are you? Medusmita? Medusmita, unmute yourself.
Now I invite Senior Obstetrician, Consultant Obstetrician and Gynecologist, Dr. Asha Agarwal, to start the session with Module 1, the new amended MTP Act.
Sorry, Medusmita, chairperson ki hol? Medusmita?
Yes, ma'am.
Chairperson.
Chairpersons, I also welcome our chairpersons for tonight, Senior Obstetrician and Gynecologist, Dr. Sangeeta Dauka. Ma'am, good evening, ma'am. And also
Dr. Haramba Bhatto.
Dr. Haramba Bhattacharjee, Senior Gynecologist. Welcome, sir. They will be the chairperson for tonight. We start the session with Dr. Asha Agarwal, Senior Consultant Gynecologist, Guwahati, with Module 1, new amended MTP Act.
Good evening, President Goggs and Secretary Goggs, and good evening to my chairpersons and all other eminent faculties present in this forum. Today, I am going to speak on Medical Termination of Pregnancy Amendment Act. There are a lot of changes which has taken place in this act. So today, I would like to highlight all those things which has come into commencement now for the change. So the objective of the module is the evidence dissemination. We will take a closer look at what are the new laws and what are the changes in the rules. So unsafe abortions in India lead to mortality, morbidity, and hamper women's and girls' full participation. As already our president has spoken to us, 8% of maternal deaths per year due to abortions, which happens in India, is the third leading cause of maternal mortality. Nearly 2 out of 3 of the abortions performed are deemed unsafe, and nearly half of the pregnancy-related deaths are in women and girls under the age of 24 years. This data has been collected from the Ministry of Health and Family Welfare from the Government of India 2015 to 2017. Now, let us know when the abortion is considered safe. WHO says that abortion is safe when both the criteria are met, like by appropriate methods, when the abortion is done with appropriate methods and is done by trained persons. When these two criteria are met, then according to WHO, the abortion is safe. It is less safe when there is only one criteria met, like appropriate method is there, but the trained person is not there. Then it is less safer. Either of the criteria is not met. When both the criteria are not met, then it is totally unsafe abortion. So medical termination of pregnancy amendment is safe and comprehensive care, which is mandated by law, is the salient features of this MTP Amendment 2021, which says that there are certain modifications in requirement of the provider, like the previous act, which said that there is requirement of opinion of one provider for MTP up to 12 weeks. But the recent amendment has changed that requirement for opinion of one registered medical practitioner for MTP up to 20 weeks of gestation. Then requirement of opinion of 2 providers for MTP for 12 to 20 weeks, which was in the previous act, but now it is requirement of 2 registered medical practitioner for termination of pregnancy from 20 to 24 weeks of gestation. In this amendment, the weeks of gestation has been increased to 24 weeks. So the potential outcome, what we see here is there is increase in the number of facilities, especially in public sector like primary health centers eligible for service provision till 20 weeks. Earlier, it wasn't till 20 weeks, which we were doing till 20 weeks. It wasn't till 24 weeks. So the salient features, again, we continue with the same thing. There is modification for the vulnerable group of women. In the previous act, the MTP was permissible beyond 20 weeks when only it is immediately necessary to save the life of pregnant women. But now in the new law, it has been enhanced the upper gestation limit from 20 to 24 weeks of special or vulnerable categories of women, and also further enhancement for the birth defects which are not compatible with life on medical board consensus. The potential outcome, what we see is that there is increase in access for vulnerable women to safe and legal abortion services defined by the Rules Committee, includes violence victims, minors, among the others. Now, again, there are modifications in the birth defects and congenital anomalies. The previous act says that pregnancies could be terminated only up to 20 weeks in this condition also. But now the upper gestation limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by a medical board. The potential outcome is this, that increase in access to safe and legal abortion services who often seek service laid beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Again, there is some modification related to marital status. In the previous act, the condition of failure of contraceptive was applicable for only married women or her husband. But now, according to the new amendment, condition of failure of contraceptive to be extended for any woman or her partner. The potential outcome is that increased access to safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. Again, there are some insertion of new clause for strengthening this privacy. The previous act says that medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under authority of law. But the new law says that the name and other particulars of a woman whose pregnancy has to be terminated shall not be revealed except to a person authorized by any law for the time being enforced. But the potential outcome, what we see here is there is increase in privacy and confidentiality of abortion seekers, increased demand, but need to safeguard rights and dignity of women and provide respectful, bias-free services, including counseling and contraception. Again, it prioritizes the confidentiality and safety. Name other particulars of women seeking abortion to be confidential except to a person authorized in any law for the time being enforced, what I have said already earlier slide, in the previous slide. And the new law says that the ground of failure of contraceptive has been extended to women and her partner. The other rules under the MTP Amendment Act 2021, which comprises mainly of special and vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks, and the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age, and the powers and the functions of the medical boards, OB/GYN, pediatrician plus radio, when available, formed for each state and mandated to provide timely evidence-based decisions. So the rules, which are for special category women eligible for MTP between 20 to 24 weeks, says that the ladies who are survivors of sexual assault, rape, or incest, and the women with pregnancy in humanitarian settings or disaster and or emergency situations as declared by the government. Change of marital status during the ongoing pregnancy, either by widowhood or by divorce. Women with physical disabilities, major disability, as per criteria under the Disability Act, or women who are mentally ill, including mental retardation, and those minor girls, and also the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So the rules under MTP Amendment 2021 for the registered medical practitioners are that the registered medical practitioner defined in old Act as MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in a hospital, or a medical practitioner who has completed 6 months of house surgency in OB/GYN, or a medical practitioner who holds PG or diploma in OB/GYN, medical practitioner who has experienced at least 1 year in practice of OB/GYN. So one registered medical practitioner opinion is required up to the age of 20 weeks, up to the gestational age of 20 weeks, and 2 RMP opinion is required up to the gestational week of 20 to 24 weeks, and opinion of medical board is required beyond 24 weeks. So the norms for registered medical practitioners under the Amendment Rules 21, an additional category of provider has been added for termination of 9 weeks, up to 9 weeks with medical methods. Registered medical practitioner with experience in practice of OB/GYN at any hospital for 3 months, or training with performance of 10 cases of MTP by medical methods of abortion under supervision of a RMP in a hospital established or maintained, or a training institute approved for this purpose by the government. So again, this law says that one registered medical practitioner's opinion is sufficient up to 20 weeks, and 2 registered medical practitioner's opinion is required from 20 to 24 weeks, and medical board's opinions is required beyond 24 weeks. So the norms for registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age according to this new amendment law 2021 says that till 9 weeks, experience and training requirement for registered medical practitioner is experience at any hospital 3 months in practice of OB/GYN, or has independently performed 10 cases of MTP by medical methods of abortion under supervision of an RMP in a hospital established or maintained, or a training institute approved for this purpose by the government. And a practitioner who has assisted a registered medical practitioner in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Again, a practitioner who holds a postgraduate degree or diploma in OB/GYN. And the next is a practitioner who has completed 6 months of house surgency in OB/GYN. Fifth one is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OB/GYN. Opinion of 1 RMP is required. The norms for the registered medical practitioner whose opinion is required for the termination of pregnancy at different gestational age, like till 12 weeks. Then again, the medical practitioner who had assisted a RMP in a performance of 25 cases of MTP, of which at least 5 have been done independently. The law is saying the number of MTPs are increasing. As the gestation age is increasing, the practitioner has to assist the number of cases more. And the second holds the same. The practitioner who holds a postgraduate degree in diploma in OB/GYN, and practitioner who has completed 6 months of house surgency in OB/GYN, and a practitioner who has experienced at any hospital for a period of not less than 1 year in the practice of OB/GYN. So here, opinion of 1 registered medical practitioner is required. And for beyond 12 weeks to 20 weeks, the experiences and the training required for registered medical practitioner is that a practitioner who holds a postgraduate or diploma degree in OB/GYN. The second point is the practitioner who has completed 6 months of house surgencies in OB/GYN. And third is a practitioner who has an experience at any hospital for a period of not less than 1 year in the practice of OB/GYN. Here, till 20 weeks, opinion of 1 registered medical practitioner is required. Then beyond 20 weeks, till 24 weeks, the experience and training required for registered medical practitioner is the practitioner who holds PG or diploma degree in OB/GYN, And second point is the practitioner who has completed 6 months of house surgency in OB-GYN. Third point is practitioner who has an experience at any hospital for a period of not less than 1 year in the practice of OB-GYN. Here till 24 weeks to register medical practitioner's opinion is required. Beyond 24 weeks, experience and training requirement for registered medical practitioner includes who holds a postgraduate degree or diploma in OB-GYN and a practitioner who has an experience at any hospital for a period of not less than 1 year in the practice of OB-GYN. Opinion of medical board is required for the termination procedure when advised by the medical board is carried out with all safety precautions along with appropriate counseling at an approved place. So the composition of medical board constitutes a gynecologist, a pediatrician, or a radiologist, or a sonologist. So the powers of medical board are that to allow or to deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the woman at that gestation age and whether the fetal malformation has substantial risk of it being incompatible with life or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. Second point is to co-opt with other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. Functions of the medical board is to examine the opinion, examine the woman and her reports, would approach for medical termination of pregnancy, and to provide the opinion of medical board in Form D, which is already there, with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. This is a very important point for the medical board. They have to give their opinion in 3 days. So the termination, if taken, decision is not delayed unnecessarily. And the third point is to ensure that the termination procedure, when advised by the medical board, is carried out with the safety precautions along with the appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. Here, the FOXI has an important role to play in ensuring there are functional medical board in every state as it is stated in the MTP Amendment Act. But in our place like Guwahati, yet we need to form the medical board. So this is all about the Medical Termination of Pregnancy Amendment Act. We need to know everything about it. Thank you all for listening.
So this was our amended new MTP Act. Thank you, ma'am, Dr. Asha Agarwal, for the informative session. For those who have joined late, welcome to the GOGS FOXI Respectful Abortion Care CME tonight. We have our chairpersons for tonight, Dr. Sangeeta Dauka ma'am, Senior Consultant Gynecologist from Guwahati, and Dr. Heramba Bhattacharjee sir, Senior Consultant Gynecologist. I request all to put their questions in the chat box, which will be answered at the last of the session. Next, we are going to see a video, the guide to right approach to MTP.
How to talk about abortion, a guide to right-based messaging. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid
Madam, video
this
is not
as
playing, madam.
terminate
We can't
may
see
have
the video.
negative
Video is not
connotations for
playing.
some people.
We can't see the
For
video, madam.
example,
I'm playing again. Is it playing now?
how to talk about abortion.
Madam, there's an audio, I think, MP4, right?
Oh,
Audio file.
No, it's a video also. The video is not playing.
No, madam.
Video is not playing.
Try to play from your side.
Huh?
I don't have that videos with me, ma'am.
Okay. The first PPT. The first PPT. See,
Hello, Mridusmita.
ma'am, মোৰ তাত play হৈছে মানে মই share video কৰিছো.
Share video to আহা নাই খালি আমি হেৰি মাতটোহে শুনিছো।
এতিয়া চাওকচোন এতিয়া মেম এতিয়া চাওক
নাই নাই তোমাৰ primary
বাইদেউ মই ট্ৰাই কৰিম নেকি? হেল্ল'?
otherwise we can finish that presentation
No,
that
Asha Midusmita, Asha Baido can try and then play the video. It's the same thing.
Guide to stigma.
what about Sangeeta, what do you say? Should we finish the talk then start the videos because video is giving some problem?
Screen.
Chairpersons, please unmute.
Guide na. Happen?
Ma'am, is it playing now?
Now, yes, Midusmita, just start playing. I think it will come now.
No, Asha
Yes.
ma'am is playing probably.
চোৱাচোন মৃদুস্মিতা
এবাৰ আমি দেখিছো ma'am.
No,
হ'ব?
Madam, we can't hear you, madam.
Ma'am,
The voice.
to add কৰি দিয়ক. Voice to
Madam,
add.
these videos are there in the third PPT, madam. So if
Yes.
you go on third PPT, then the videos will be played. Automatically one up to the other.
Yes.
After the second topic, the third topic, then the fifth slide and the eighth, ninth slides, we have these videos. We can play this video simultaneously.
Okay. Okay, then we go to the next session then. Nilakshi ma'am, do we go to the next module?
Hello.
Ma'am, can we go to the next module 2 then?
Chairperson of what?
Sangeeta ma'am, do we play the video later or and go to the module 2 now?
Sangeeta, unmute yourself. Sangeeta, unmute. You are muted.
Midusmita,
Yes.
Midusmita, there is written a host can unmute. So you try to unmute Sangeeta Baido.
How to talk about abortion, a guide to right-based.
Video play হৈছিলে নেকি দীপ্তি বাইদেউ?
Yes, sir. এইটো কাৰণে
You try to unmute Sangeeta Baido, the chairpersons, and ask them permission to
Okay.
go for the second session.
Okay. Unmute করে দিয়েছে, ask to unmute. No, Diptiva, I cannot unmute Sangeeta ma'am.
Yeah, hello. Yeah, can you hear me now?
Yes, ma'am. Yes.
Yeah, yeah.
Ma'am,
I think if the video is not playing, we can go to the next talk or
next
what?
module. Okay, ma'am. Okay, thank you so much, ma'am.
Yeah, the next, yeah.
So now I invite Dr. Amrit Krishna Bora, consultant gynecologist and obstetrician. He will be talking on module 2, safe abortion.
Good evening, everyone. Am I here?
Yes, you can. You're audible. Yeah.
Okay, my screen share is okay now.
No, screen share is not showing. Yes, we can see.
Okay, okay. My topics is the abortions guidelines, safe abortions, and this updates in technology. Overview of the existing guidelines, pre-abortion assessment, medical method of abortion, and surgical method of abortion. There's 4 topics I'm going to cover now. All these technical guidelines has been depend upon the some who on safe abortion. That is published under the practice of handbook for safe abortion. Then another handbook has been published by the WHO, safe abortion technical and policy guidance for health system, and another is for the MMA. These are WHO national publications on safe abortion on 2012. That is for technical and policy guidance health system. 2000. That is for clinical practice handbook for safe abortion, and 2015. That is that workers in the role in providing safe abortion care and post-abortion contraception. 2018, that is medical method of abortion guideline. And 2019, that is the consolidated guidelines for self-care intervention for health. In case of Indian scenario, we have the adaptation of WHO safe abortion guidelines in India. And another one is another landscape assessment of availability and quality of medical abortion commodities. Minister of Health and Family National Guidelines on Safe Abortion, that is the gazetted notification done on the 25 March on 2021, and that rules has been changed in 24 September 2021. That has been nicely elaborated by previous speaker. All guidelines have 3 key areas in management of abortion safely: pre-abortion care, abortion care method, and aftercare and follow-up, including post-abortion contraception and counseling. All these things depend upon the decision making. This decision making is just we are going to do like the undergraduate studies, like the medical history, physical examination, laboratory and other investigation if necessary and is available in the facility, and discussing contraceptive option. If the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on the duration of her pregnancy and her medical condition, decision-making process. Pre-abortion assessment and counseling. Component of pre-abortion assessment for women seeking first trimester abortion will be again the detailed history taking, general, physical, and pelvic examination. It comprises with a bimanual examination also, and laboratory and other investigations, and decision-making information on counseling. Now the gestational age determination by LMP or physical examination. We have seen the pregnancy dating by physical examination, both bimanual pelvic and abdominal examination. That is uterine size up to 4 weeks. The uterus increase in size by approximate 1 centimeter per week. Then after 12 weeks of gestation, the uterus rises out of the pelvis. After 15 to 18 weeks of gestation, the uterus reaches the midpoint between the symphysis pubis and the umbilicus. And 20 weeks gestation, the uterus reaches the umbilicus. And after 20 is all your esteemed audiences knows these things only. It's just I'm going to skip it now. Then there are the key consideration of limitation to dating by uterine size on physical examination. It is uterine malformation or fibroids, multiple gestation, marked uterine retroversion, obesity, molar pregnancy. Key consideration: when the uterus that is smaller than expected may indicate the woman is not pregnant. There may be inaccurate menstrual dating. There may be ectopic pregnancy or abnormal intrauterine pregnancy. In example, spontaneous or miss abortion. Sometimes a uterus that is larger than expected may indicate inaccurate menstrual dating again, then multiple gestation, uterine abnormalities such as fibroids, and molar pregnancy. Routine lab test not a prerequisite for abortion services. Tests that may be performed as per individual risk factor and finding of physical examination, that is the pregnancy test if pregnancy is unconfirmed, hemoglobin or hematocrit for suspected anemia, research testing where Rh immunoglobulin is available for Rh negative women, HIV testing or counseling, STI screening usually performed during the pelvic examination, other laboratory tests as indicated by medical history, that is a kidney or liver function test, etc. Ultrasound is not necessary unless to diagnosis of pregnancy or not certain or suspecting ectopic or miss abortion. Pre-abortion counseling, we have to ask about what is her thought about terminating the pregnancy and why she goes for termination. Then we have to inform her that the early abortion is safe for her, and there is an importance of a trained provider performing the procedure for safety. Then the available method of abortion, both the medical method or the vacuum aspiration, which for the early pregnancy, and the risks and warning signs associated with the abortion method. And we have to inform that without contraception, she can be pregnant as soon as 14 days after an abortion, and a resumption of her normal activities, including sexual intercourse or any other follow-up care. And the documentation is very much needed in these cases: informed written consent and decision to accept post-abortion contraceptive. Even if she is not willing for contraception, she will be provided with the abortion services. Clinical management of abortion. Abortion care less than 12 weeks. This global recommendation is then mifepristone and misoprostol. That is one option. Misoprostol only, the second option, then vacuum aspiration. And more than 12 weeks, again the mifepristone and misoprostol, and misoprostol only misoprostol, and dilatation and evacuation, DNE. Dilatation and curettage is completely obsolete now. Government of India recommendation, medical is until 9 weeks only. Then up to 7 weeks or 49 days, mifepristone 200 milligram oral. Then wait for 20 to 48 hours. Then the misoprostol. That is the medical method of abortions. Abortion up to 9 weeks only. In case of 7 to 9 weeks, that is a 49 to 63 days. Again, mifepristone 200 milligram oral. Wait for 20 to 48 hours. Misoprostol 800 micrograms, sublingual, buccal, or vaginal. Oral route in case of higher gestational age is not recommended due to the efficacy. So in case of method for first trimester abortion, MMA or surgical method, either is a manual vacuum aspirator or EVA. Tablet mifepristone and tablet misoprostol. Mifepristone, and you all know the antiprogestin inhibit actions of progesterone, and it interferes the continuation of pregnancy. Initial oral dose of mifepristone followed by misoprostol, a prostaglandin E1 analog. Misoprostol causes cervical shortening, uterine contraction, expulsion of product of conception. And misoprostol. In K1, we are giving the mifepristone oral, and in case of the Rh negative, we go for anti-day in the first day only. And day 3, after 48 hours, mifepristone administration has of the 48 hours after mifepristone administration, we have to give the 400 microgram of misoprostol. 200 microgram is sublingual, buccal, vaginal, oral, or in case of 7 to 9 weeks, 800 microgram sublingual, buccal, or vaginal. In addition, we can use the analgesic, ibuprofen, antiemetic, and offer contraception also. And in day 15 follow-up day, we have to confirm and ensure completion of product of the procedure, that everything has been evacuated, means expelled out, and offer contraception if not already done so. Characteristics of different routes of misoprostol administration for first trimester abortion. Order recommended up to 7 weeks, 49 days for first trimester abortion. Side effects include diarrhea, nausea, fever, and chills. Buccal pills are placed between the gums and cheek and swallowed after 30 minutes. There is a fever, chills, then with the vaginal route. There is more fever, chills, and sublingual pills are placed under the tongue and swallowed after 30 minutes. There is more fever, more increased fever than the buccal route, then chills, diarrhea, vomiting compared to the vaginal route. And the fastest onset of action and highest plasma concentration level. And vaginal pills are placed in the vaginal furnaces, and the woman is instructed to lie down for 30 minutes. Pill fragments may be visible, lowest rate of side effect. So according to the route of administration, sublingual is the best, and then the buccal, then oral, then the vaginal one. These are showing the pictures. Then whole drug regime, dose schedule for medical abortion. Recommendation is induce abortion less than 12 weeks. Mifepristone 200 microgram per oral once, and misoprostol 800 microgram buccal, per vaginal, or sublingual. And in case of going for only misoprostol, that is the alternate option, that we are going to 800 microgram buccal, per vaginal, or sublingual misoprostol. This is WHO regime. Provision of MMA services. Services should be available at the primary care level, while with a referral system in place for all required higher level care. There should be linkages there. If you are going in the chamber also, then you have to have a linkage with the hospital facility. Additional services may need to provide it to individuals seeking medical abortion. It is the counseling and testing for sexually transmitted infection like STI, HIV. There may be abuse support services. There may be intimate partner violence or domestic abuse may be there. That everything has to be giving a comprehensive services to the abortion seekers ladies. Psychological or social service may be needed, and other specialist health or medical services should be provided. Iron tablet for anemia if needed, and pain medication may be needed, and provided emotional support. Follow-up care, routine follow-up, not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess succession of the abortion. Whether we have going the complete evacuations of the product is happen or not, we have to be certain. Assess women's recovery and ask for any signs of or symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaint, and assess women's fertility goals and need for contraceptive services if not provided earlier. MMA summary is that first day visit, we have to go over physical pelvic examination, confirm eligibility, 49 days or 7 weeks of LMP, tablet mifepristone, and NTD. Tell the woman return for misoprostol administration after 2 days, contact address and phone number of the facility or center where she can go in case of any emergency, record her experience of any side effect on the MMA card. 3% women may expel completely with mifepristone alone, but misoprostol schedule should be completed. Second day visit, day 3, give misoprostol 400 micrograms sublingual, buccal, vaginal, or oral route. Observe for 4 hours. Analgesic, ibuprofen 400 milligram. Then contraceptive option. And we have to go for pelvic examination to ensure, we have to tell the woman that the mean period of bleeding is 8 to 13 days. Usually we are considered up to 15 days. And possible side effect, if there are nausea, vomiting, diarrhea, it will be more in case of buccal or oral route. Report in case of excessive bleeding, pain, abdomen, and fever. Report if there is no bleeding 24 hours after misoprostol. Consider giving additional doses of misoprostol. 75% of women abort within 4 to 6 hours after misoprostol administration. And after, on the third visit, we have to go for again pelvic examination to ensure the completion of the abortion. And we have to give the contraception option, hormonal method, condom, IUCD, or sterilization after 1 menstrual cycle. We have to tell the woman that there may be immediate return to fertility within 14 days on maybe, and a report back if there are no periods within 6 weeks of completion of the abortion process. We have to confirm the whether procedure has been completed or not by the ultrasonography if needed. Side effect and complications. There is a pain may be there. Pain, for elevating the pain, we have to be very respectful, and there is non-judgmental communications with the lady. There may verbal support should be given. There is adequate counseling. Definitely cramping pain will be there, and we have to tell them beforehand. Then their pain will be definitely reduced. Support person should be accompanied. Ibuprofen can be given. If there is persistent pain with failure to respond of these drugs for several hours, warrant evaluation of other causes such as ectopic pregnancy, infection, or incomplete abortion. Nausea and vomiting is self-limiting. Diarrhea also self-limiting. In both these cases, we have to reassure her. Infection, we have to confirm by physical examination and started the antibiotic. Action for failure, incomplete result of MMA. If there is failure of MMA, we are going to either repeat MMA or vacuum aspiration. If there is no bleeding or there is no expulsion or anything. If there is incomplete result of MMA, product has been out but it is not completed, then in that case, observe if there is no heavy bleeding, and we can go for repeat misoprostol, or we can go for surgical method evacuation in the first setting. If there, in case of observance, if there is no heavy bleeding, then uterus become normal size, then we can consider it is a abortion has been completed. And if the heavy bleeding is continue, or then in case of go for, we are going for the again surgical method of evacuation. It is the same thing if the bleeding is there. And it is the bleeding more than her menstrual cycle. If the excessive bleeding criteria is there, and the choking 2 page in 1 hour for 2 consecutive hours, and the bleeding is not subside or not decrease, in that cases, we have to ask for vital signs and do the physical examination. POC in the cervical canal, we go for the digital evacuation only. Instrumentation is not required if the POC in cervical canal. If the woman is stable and bleeding is reduces, then go for, we are going to observe and monitor vital signs and bleeding PV for 1 more hour. If the bleeding is decreased over time within 2 to 3 hours, then we have to go for routine care, keep a watch on her vitals and bleeding PV, and she can go home. If the bleeding is continue up to 3 to 4 hours, then in that case, ultrasonography indicated. If there is ultrasound reports come out, so the minimal decidual beads, there is nothing to do. If there is POC and decidual beads are there, woman is stable, we can go for misoprostol, 600 microgram oral or 500 microgram sublingually again, and we can see that the bleeding has been, the process has been completed. If the woman is not stable, then we have to go for vacuum aspiration again. And in some cases, in rare cases, continuation of pregnancy is there, we can go for again vacuum aspiration. And the recording and reporting for MM is the same as the MBA or ABA like that. Form C, consent form. Form 1 is RMP opinion. Form 2 is monthly reporting form. And Form 3 is admission register for case record. And the second method is a surgical method. Surgical method, MBA or EBA. Surgical abortion method in first trimester. Vacuum aspiration is the recommended technique for surgical abortion pregnancy up to 12 weeks. Who recommends manual vacuum aspiration as the safest method? And the procedure should not be routinely completed by sharp curettage. Sharp curettage. This is the MBA. It is a bivalve suction, manually operated suctions. The handheld aspirator used for generate vacuum. Aspirator is attached to cannula for 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. IPAS or easy grip cannula size correspond with weeks of gestational age, 8 mm cannula for 8 weeks gestation and 10 mm for 10 weeks. So easy grip cannula is available in government setup. It is available in the mainly all the health institution. IPAS has been provided it. So we have given the MBI in all the facilities, public facilities where the registered medical practitioner, trained registered practitioner is available for doing the first trimester abortions. Then EVA and the electric pump used to generate vacuum can accommodate cannula or manual vacuum aspirator with correct size tubing. The negative pressure generation both the EVA and MVA is the same. So there is not much difference between the EVA and MVA. The technique is MVA is more comfortable for the women than the EVA. And cervical priming may be considered for women with any gestational age, prepare the cervix and make it soft and easy to dilate. It is the recommended method of cervical preparation before surgical abortion in first trimester. The priming can be done with oral mifepristone 200 milligram, that is 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually, that is 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered vaginally 3 hours prior to the procedure, or laminaria placed intercervically 6 to 24 hours prior to the procedure. Procedure, important component of quality abortion care, and it reduces pain and anxiety and makes women comfortable. There are two components of pain management, non-pharmacological and pharmacological method. Non-pharmacological pain management is providing psychological support, explaining each step to the woman in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. Pharmacological pain management, source of pain and its management, that is the anxiety. We have given for anxiolytic like diazepam. Diazepam 10 milligram orally, 1 hour prior to procedure, or 2 to 5 milligram IV, 20 minutes prior to procedure. Duration of effect will be 4 to 6 hours, and there may be slight side effects like the deorientation or dizziness. The pain occurred due to cervical dilatation. We are giving the lignocaine or local anesthesia, 10 ml in 1% lignocaine, 4 and 8 o'clock position, and duration of effect will be 60 to 90 minutes. And there may be side effects like dizziness, seizures, and gastritis. And analgesic NSAIDs like ibuprofen can be given 4 to 800 milligram 1 hour prior to the procedure, and the duration of effect will be 4 to 6 hours. In case of uterine cramping, analgesic same ibuprofen can be given in the same dose, and the efficacy will be the same, lasting for the same period, and there is a gastritis. Steps of MBA and the prepare of the instrument. I think in the video it is available. Prepare for instrument. Then you have to charge the instrument by creating the vacuum, pulling the piston. Then prepare the woman, the ensure pain control medication is given at the appropriate time, and ask the woman to empty the bladder. And then perform cervical antiseptic preparation and administer paracervical block. Then dilate the cervix, then insert cannula. Then you have to insert the this vacuum aspirator and pulling discharge the piston, means cannula, and pull out the piston, and we are getting the negative pressure inside the uterus, and with a rotating and slightly downward movement, all the product will be completely come out. Rotate the cannula in 10 to 2 o'clock position with smooth, gentle motion, and release the vacuum button on the aspirator. Then 2 to 3 this in case of MA, 2 to 3 repeat procedure may be needed. Means that in surging and discharging procedure maybe 2 to 3 times you need. And the uterus emptiness can be determined by the rate of peeing foam without the tissue passing through the cannula. Then gritty sensation over the surface of the uterus, the cervix gripping over the cannula, and uterus contracting around the cannula, or increase the uterine cramping. Then we have to inspect the tissue, that the tissue has been expelled out is to correspond with the period of gestation. And we have to go for concurrent procedure like the IUCD insertion or maybe sterilization. And the instrument processing should be done with a soak in chlorine solution 0.5%, and assist disinfection and helps remove tissue and body fluid. Disinfection and the decontamination should be done. Post-procedure care is monitor heart for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that a woman has all necessary information and medication prior to leaving the facility. Documents all outcomes of the treatment, including any adverse events in the facility register and record card. Aftercare is a management of abortion complications like incomplete abortion, infection, bleeding, or ongoing pregnancy. Provision of contraceptive information and offer contraceptive counseling and methods. Assessment of any other sexual and reproductive health needs that may require additional care, maybe from other specialty also. Let's follow up. No routine follow-up unless mesopost is given alone. That is in the new recommendation. In summary, India has made historic progress in improving access to the safe abortion. Not much has changed the technological update in the last decade. As provider, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. Thank you very much.
Thank you, Dr. Ambedkar Vora. It was wonderful listening to you. For those who joined late, again, I would like to invite all for the Gogs Foxy Respectful Abortion Care CME tonight. We have with us chairpersons, Senior Consultant Gynecologist, Dr. Sangeeta Dauka, and Senior Consultant Gynecologist, Dr. Heramba Bhattacharjee. Now we go to module 3, Safe Abortions, Values, Evidence, Rights and Respect. We have with us speaker, Dr. Swagata Bosha, Consultant Gynecologist, Sarthi Hospital, Nalbari.
Thank you, ma'am. Thank you for letting me be a speaker today. Thank you, organizers. And should I start my share screen?
Yes, you may.
I hope it's visible.
Yes.
I'll make it full screen. It's visible, right?
Yes.
So this is module 3, Safe Abortion Values, Evidence, Rights, and Respect, SAVOR. So this module aims to define respectful abortion care according to WHO standards. It highlights how norms and stigma affect services, provides WHO saver resources for respectful abortion care. The momentum has been created. Law has changed. Dissemination needs association and OB/GYN provider support. FOGSI has been the largest provider base for abortion care. Of course, COVID has made online training possible so that respectful abortion care can reach all providers. MMA uptake has increased. It is early, safe, and ensures no PCP entity confliction. Patient safety, respect, and equality matters more than ever, and we all have a role to play. So, what is respectful abortion care? This has been adopted from respectful maternity care recommended by the World Health Organization. So respectful abortion care refers to care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. What is respectful abortion care? In simpler terms, respectful care means you as a provider or as a patient treat and are treated with dignity, empathy, and compassion regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, or abortions. If you ever feel something isn't right, speak up. As a health professional, it is our duty to listen and support because communication is the key. What are norms and stigma? Stigma and norms perpetuate disrespect and abuse. Categories of disrespect and abuse includes physical abuse, which may include slapping, intimidating physically, verbal abuse, non-consented care, shouting, screaming, sexual abuse, abuse of power, taking advantage, also stigma and discrimination. I think it will be showed in the videos. Failure to meet professional standards of care, poor rapport between women and providers, health system conditions and constraints. Rights of every woman includes freedom from harm and ill treatment, right to information, protection under laws like MTP, POCSO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care. Right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. The domains of respectful abortion care includes 12 domains of respectful abortion care, being free from harm and mistreatment, maintaining the privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communications like soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraceptive advice and commodity security, continuity of care and counseling. It's time to strengthen. Sorry?
You missed the video, madam. Can you go back to the next slide?
I don't have the video actually. I thought it will be played together. I don't.
Go back, ma'am.
Is it okay?
Just go back. Other slide, madam. Next slide.
I'll continue with the slide.
You have to go back, madam. Back when you're going forward.
Yeah, okay.
Backward.
Yeah.
The other one.
Yeah.
So, other slide, madam. Go to next. There will be a play button in the down, madam. Click on the play button.
Okay. It shows media unavailable.
Okay, then, man. I'll play the video after your presentation. There will be 3 videos.
Okay,
I'll play all the 3 videos.
Okay, thank you.
Okay.
It's time to strengthen implementation. So the important changes for provider opinion: every patient is an opportunity for respect, and as providers, onus is on us to educate and also reduce sex selective abortion. As the previous speaker ma'am has already elaborated this, up to 20 weeks of gestations, we need one RMP, 20 to 24 weeks of gestations, 2 registered medical practitioners, and beyond 24 weeks, the medical board comes into play. So as one provider, there is more responsibility: counseling, contraception, referral, and compassionate care. The eligibility has expanded. It includes especially young people, survivors, unmarried women. Everyone needs an unbiased care, and we need to overcome our own biases. So all women are included up to 20 weeks of gestation. 20 to 24 weeks, the special categories like rape, less than 18 years, and for birth defects, there is no gestation limit, and of course, the board is needed. So 20 to 24 weeks for special cases needs sensitivity, judgment-free, timely services. So the new act prioritizes confidentiality and safety. As we know, respect begets respect. As providers, we need to be mindful of socio-cultural aspects. Names, this has been mentioned earlier in the act, names and other particulars of any woman seeking abortion to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to woman and her partner. Respect, quality, and dignity at all types of abortion. Guide, I don't think so. This will also play. It shows media unavailable, guide to avoiding stigmatizing language. So can I continue?
Yes, ma'am. You don't have VLC player to play the video support.
Yeah, actually the video is not there.
That's what
So,
I'll do it last. These also
okay.
video play in the
Okay.
last.
Okay, thank you. So this is again a video, WHO training for safe the Saver toolkit. So there are some self-paced games like Cross the Line, Personal Compass. So from 1970, unsafe abortion, we have come to safe abortion in 2000s, and now 2020 is respectful abortions. So there are some recap questions. According to the WHO, restricting access reduces the number of unsafe abortions. True or false? Of course, it is false, because because abortion is considered safe when both criteria are met, that is safe, that is by appropriate methods and by trained persons. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? The answer is no, because now it has been extended to 24 weeks of gestations. Of course, 2 registered medical practitioners will be required. So in India, abortion is legal. So let us make it safe and respectful. Thank you.
Thank you, Dr. Swagata. It was a wonderful talk. And for those who joined us late again, welcome to the CME tonight. Our next session, we go to Dr. Rajashri Sharma, consultant gynecologist, for module 3B, pre and post-abortion FP counseling. Dr. Rajashri.
Sorry to interrupt. Shall I play the videos?
No, the 3B now, module 3B. The next PPT.
Madam, there were 3 videos in the last section, ma'am, previous
Just
section.
videos, let them pay the videos.
Okay.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high-quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, Participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So welcome back to the CME. Now I invite Dr. Rajeshri Sharma for her module 3B, pre and post-abortion FP counseling. Dr. Rajeshri Sharma, consultant gynecologist, Guwahati.
Good evening, chairpersons, respected seniors, and my dear colleagues. I'm very glad for the opportunity provided to me to discuss a very important topic, which is pre and post-abortal counseling. Okay.
Midusmita?
Yes, ma'am. Yes, Diptiba?
Yes, if the Rajeshri is facing problem, then can you share the slides for her?
Okay, okay.
Yes,
Yeah,
ma'am. I'm facing some problems.
Okay, yeah,
Yeah, you
Rajeshri,
share the slides for her.
I'll try.
Okay.
I'll try. Okay.
Thank you so much, ma'am.
Module 3B counseling. Can you see? Diptiba, can you see the screen?
No, slides are not visible.
Okay, okay.
Hello?
Yes. Yeah.
Midusmita, it is, have you shared the slides?
Yes, I'm sharing the slides, but is it showing? Just let me know.
No, it's not coming. It's not coming.
Give me one more.
Yeah.
Now?
Wait.
Now?
No, it's not coming. Just wait for today, I think.
Please ask the person with the PPT.
Ask the technical person?
Yes. Okay. Backward use. Mr. Shriman, can you hear me? Mr. Shriman, can you hear me?
Yes,
Yeah, now it's visible.
Okay.
For the delay, so I welcome you all to the pre and post-abortion family planning counseling, leveraging technology for referrals and online consultations, which is a part of Respectful Abortion Care, Joint FOXI and WHO initiative. Can we move over to the next slide? Thank you. So coming to counseling, counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So basically, it is an emotional support and guidance which is opted to a woman who have come for abortion, which can be either of choice or because of any medically deemed reasons. So coming to pre and post-abortion counseling. It is an integral part of comprehensive abortion services. It is as important as the procedure. Women may need help in decision making. Wherever needed, the spouse should also be counseled. So what is a critical role? First of all, it helps the women decide about the termination of pregnancy, which may be either by choice or because of any sort of medical reasons. Then coming to, we have to help the women to choose the method of termination, giving her about helping her with all the advantages and disadvantages of the methods which are now available. Then we have to ensure that there is delivery is complete, information and the procedure is also complete. We have to help the women to adopt a contraceptive method at the end of the procedure if she is willing. So coming to the procedure, first of all, we have to ensure that privacy and confidentiality is maintained. We have to assess the situation, but we cannot be judgmental. Rather, we should be sensitive. We have to establish a good rapport with the applicant. We have to use a simple language, preferably the woman's own language, and allow the woman to clarify all her doubts. If she has made her mind for termination of her pregnancy, we have to assess her for the procedure. What is the relevance of peri-abortion family planning counseling? The importance is that we have to counsel the women regarding the quick return of fertility, which can appear as soon as from 10 to 14 days. It also gives an opportune time for contraceptive acceptance. A minimum of 6 months of gap has to be given before the next pregnancy. Apart from this, it also has health benefits and better future pregnancy outcomes for the lady. 90% of the abortion-related maternal mortality can thus be prevented by ensuring contraception. When to start? The most important is that whenever she comes for her first visit or first consultation, we can give her a family planning counseling. However, there is an exception if it is a grief management or delay, which we can see in case of missed abortion or in case of abortion due to some medical complication. What to counsel? Most important is return of fertility, which can occur from 10 days to 4 weeks. We have to help her with the choices. We have to give her method-specific counseling, which should include all the things that are associated with the method, what are the advantages, disadvantages, or what sort of complications she might face. Also, we have to ensure about her high-risk behavior wherever applicable. However, if the woman is not willing for any contraceptive method, we should not refuse MTP. Rather than that, we have to try and counsel her after the procedure. Even if she is not willing, we can call her for follow-up in a week's time and then counsel again. So how to assess for suitability of post-abortion contraception? What are the general guiding rules? First of all, the abortion process should be complete. There should not be any existing infection. There should not be any injury to the genital organs, and the chances of fresh pregnancy should be ruled out. The post-procedure counseling also has a critical role. First of all, we have to ensure that the woman has understood the precautions and care needed during the post-abortion period. It also gives us an opportunity to counsel for contraception in case it was not previously accepted. It reinforces the need for continuing the use of contraceptive method which was chosen by her or her partner. Let us come to the procedure. First of all, we have to continue to ensure there is privacy and confidentiality. We have to reassure her in case of any problems. So basically, counseling is a two-way communication. We have to talk to her what are the problems that she is facing, or we have to elevate any sort of anxiety that she is facing relating to family planning procedures. We have to repeat the information about the post-procedure care and also inform her about the danger signs. The danger signs have already been discussed before in the slides. Post-abortion family planning counseling can be divided into two parts. If it has already been opted, then we have to appreciate the decision. Immediately, we can go for intrauterine copper devices. We can also go for MPA injections. Then ongoing oral pills can be continued. However, we have to always continue with our follow-up protocol. Continuity, reproductive intuition, and cards should be maintained. If family planning has not been undecided, then we have to allay the anxiety. We have to discuss about the importance of immediate adoption and chosen. Extended period of abortion should also be discussed. The couples should be counseled, and emergency contraceptive pills can also be discussed. So what are the methods which are available for post-abortion methods? Post-abortion contraceptive methods, first of all, we can go to the barrier methods, which are the condoms. In case of first trimester abortion, it can be started as soon as sexual activity is resumed. In case of second trimester abortion also, it can be started as soon as sexual activity is resumed. The advantages of condoms are that they have no hormonal side effects. It can be used without consulting a health provider. It is easily available. Apart from family planning, it also prevents against STDs. Sorry, the slides have become blurred. Ma'am, the slides have become blurred.
Mr. Shriman, can we correct it? Yeah, now, yeah.
No,
Okay.
madam, might be
No,
an
again, it
internet
has
issue.
become blurred.
Might be an internet issue, ma'am. I can see the slides.
Okay. Dr. Rajeshri, if you have in your laptop or something, you can read it out.
Okay, ma'am. I just need a couple of minutes to open it again.
Okay. Yeah, you can see now probably. See on the screen?
Yeah, ma'am, it's visible.
Okay.
Thank you, ma'am.
Okay.
So coming to the second method, which is intrauterine contraceptive device, which can be IUCD 380 or IUCD 375. During the first trimester abortion, it can be inserted immediately or up to 12 days after confirmation that the abortion process is complete. In case of medical method of abortion, it can be inserted around the day 15 of the process, provided complete expulsion of products has been confirmed and the risk of infection or any other contraindication is ruled out. Now, coming to second trimester abortion, IUCD can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. The salient features of IUCD is that it is highly effective. It provides long-term contraceptive for 5 years in case of IUCD 375 or 10 years in case of IUCD 380. It can be provided by trained doctors, MBBS and above, sometimes ANMs and nurses after first trimester surgical abortions, or by trained doctors only after medical methods of abortion, and by PPIUCD trained doctors after second trimester abortions. There is no interference with sex. There is immediate return to fertility on removal, and there are no hormonal side effects. Then we have the hormonal contraceptions, which can be either your combined oral contraceptive pills. This can be given immediately or up to 7 days after first trimester abortions using surgical method. In case of medical methods of abortion, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of completed abortion. Coming to second trimester abortion, we can give combined oral contraceptives immediately or up to 7 days after abortion. Salient features of oral contraception is that it can regulate menstrual cycles. It can be provided by all healthcare workers after first screening by trained provider. There is no interference with sex. It offers protection against ectopic pregnancy, endometrial and ovarian CA, and benign diseases such as fibrocystic and fibroadenomatosis. However, it is not suitable for women who have breastfeeding babies less than 6 months old. Then coming to long-term injectables, which is the medroxyprogesterone acetate injections, which are easily available nowadays. So the timing after abortion, in case of first trimester abortion, it can be given immediately or up to 7 days after abortion using surgical method. In case of medical means of abortion, it can be started on day 3 with a dose of misoprostol. Coming to second trimester abortion, it can be given immediately or up to 7 days after abortion. The additional information which can be shared is that these are highly effective. Confidentiality and privacy is maintained. It can be provided by doctors, MBBS and above, Ayush doctors, ANMs, nurses, however, after first screening by an MBBS and above doctor. There is no interference with sex. There is no effect on the quantity and quality of breast milk. It has no estrogenic side effects, and it also offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Then we have the permanent methods. Permanent methods can be either your female sterilization or vasectomy, which is male sterilization. So female sterilization, in case of first trimester abortion, it can be performed after abortion. However, in the absence of any infection or severe blood loss, or it can be confirmed after 7 days, both mini-lap and laparoscopic sterilization can be done. In case of medical methods of abortion, it can be done only after the first menstrual cycle. Coming to second trimester abortion, mini-lap sterilization can be performed concurrently or up to 7 days after abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization, however, is not recommended. Coming to the additional information, first of all, it is a permanent method of contraception. It is highly effective immediately. There is no interference with sex, no effect on breastfeeding. It has no long-term side effects, and it also offers protection against ovarian cancer. Now coming to male permanent method, which is vasectomy. It is performed on males, which is independent of the timing and procedure of abortion. The salient feature is that it is very effective. Permanent method of contraception, there is no interference with sex, no long-term health risk. So there is a table which is showing us about the methods which we can use. For example, in case of medical means of abortion, immediately within the day 3, we can start oral contraceptive, injectables, and semprofen. IUCD can be given only after 15 days of the abortion process, provided there is no infection or no other contraindication. Then coming to contraceptive methods after vacuum aspiration, all the contraceptives can be given immediately after vacuum aspiration, such as your combined oral contraceptives, injectables, semprofen, IUCD, and permanent methods can also be provided, which is tubal ligation. Now coming to SRH services, which is teleconsultation and other technology. So leveraging technology, which is coming under service provision, it has become very important considering the COVID era. First of all, we have the opportunity of coming into teleconsultation. Then we can go for telecounseling, teleguidance, telereference, and even telelinkage. So let us discuss about teleconsultation and other technology.
Now you can see. The next slide, please. Mr. Shriman, can we go to the next slide? The next slide. The next. Yes.
So teleconsultation, what are the strengths? Number one, during the COVID era, it has given us a means of even continuing our consultation on telecommunication. It is approachable throughout the process. Confidentiality is maintained. Awareness, spread out questions and answers are given at ease. However, there are some weaknesses. We lose out the advantages of face-to-face conversation, and we also lack demonstration of the process. Coming to opportunity, privacy and comfort is maintained. It is cost saving and there is cut down on the number of visits. However, there is a threat that missed opportunity and misdiagnosis can be there. So what is the applicability of components of comprehensive abortion care? First, assessment has to be there. We have to confirm the diagnosis and also we have to assess about what is her contraceptive need. Counseling can either be through video conference or through Zoom meetings. Then follow-up has to be there, which consists hybrid services, which can consist of either one visit or in case of medical methods of termination, we can go up to 3 visits. So what is the take-home message? First of all, we have to realize the need of post-abortion family planning counseling. Then we have to bring the couple on board and strive for 100% coverage. Capitalize on the basket and applicability in the post-abortion period. Technology, as far as possible, can be made into use. There is a scope for entry in comprehensive abortion services. However, the concern is about policy, malpractice, service cost, and access. Adolescent reproductive health needs both online and offline services.
I think Dr. Rajeshri Sharma, I think we've come to the end of your presentation probably.
Thank you, ma'am. Thank you so much.
The last slide is showing something else. Yeah. Thank you, Dr. Rajeshri Sharma, for the wonderful presentation. Now I would like to invite our chairpersons, respected Sir Dr. Herambo Bhattacharjee sir, and ma'am, Dr. Sangeeta Dauka ma'am, to take up the sessions and say a few words.
Thank you, all participants and speakers. One thing I want to add, the medical board, state medical.
Sorry, you're muted.
Yeah. Hello?
Hello.
Can you hear us?
Hello.
Yes, we can hear you. We can hear you.
Yeah. Yeah, because like we are being always muted. Okay, thank you for all the nice talks. Thanks to all the speakers, and I'm sure we have learned a lot. And it's going to help us in the future. And Dr. Herambo wants to say something.
So, as 15% of unsafe person contributes 50% of total MMR. So we can avoid unsafe person and reduce the MMR. Number one. Number two, for proper disposal of cases in proper time, in a short time. So, state medical board should be extended up to impossible to dispose early decision making. So it should be district medical board. Already all these things have specialists, three specialists like gynecologists, anesthesiologists, and radiologists. This is my suggestion. Thanks a lot. They have learned a lot.
Thank you all. It was a wonderful presentation and discussion. I want to ask something, Haramboda. So they have talked about that. Can you hear me? Am I audible?
Yes.
Yeah, we can hear you.
Madam, sorry to interrupt you. I have posted posters feedback link in the chat box, madam. If you click on the link, you will be redirected to posters and feedback. Answer all the questions and submit, ma'am. And we'll take data from our backend and we'll issue the certificates.
Okay. Just I wanted to ask Haramboda, do we have such medical board in Assam?
Yeah.
Yeah.
Yeah, it's not considered yet, but we have already quality assurance committee, all three doctors in every district.
অলপ কম্পিউটাৰ ওচৰত আহক, ভালকে শুনা নাই। কম্পিউটাৰ ওচৰত আহক Haramboda.
Yes. We have already district quality control subcommittee where one anesthetist, one radiologist, one pediatrician, one gynecologist. So here in this state medical board is formed, but it can be extended to district medical board so that we can dispose the cases at earliest possible time.
So suppose we have an anomaly beyond 24, we have to refer to the board. How to address which board, like where?
As Asara said, it should be disposed in 3 days.
3 days, yeah.
But suppose the case is in Tinsukia. After coming the case report up to Guwahati, it cannot be solved in 3 days. So the doctors from this committee, state committee, may require physical examination of the patient. So if it is managed in district level, that becomes more quickful.
Okay. Now we're only in capital only we have.
Yes. Now according to this act, state capital, that is state board.
So these are the things we must know as a practitioner. Actually,
Yes, madam. May I say one thing?
Yes.
Excuse me, madam. Actually, the state district medical board has been started in Kamrun Metro. The last month there is a meeting where, according to guideline, one radiologist, one gynae, and one pediatrician. The one district medical board has been going to be formed. The process is online now for Kamrun Metro. In every district, there has to be a district medical board, and the state medical is there in the overland, like a overarching institute like that.
All the district will have one.
Yes,
they can approach the district.
Yes. Every district we have to approach, and they will see the facility. This board will see the facility whether that more than 24 weeks termination can be done. In case of where the medical college is there, then in that cases, the cases to be district medical this medical board will appoint the medical college to for the termination. And in whose district the medical college is not there, or in the process in that district, the civil hospital will be empowered for the termination more than 24 hours. Then in that cases, within the 3 days time, that termination can be done in every district.
And for the I think private sector?
Private sector also to approach to the district board. They will see if the facility maybe can be recognized by the district board. In any private facility can be recognized for the termination more than 24 weeks. But it has to be according to guideline, that it has to be by the gynae specialist.
Okay.
Dr. Murad, this board is running till last 15-20 years, not for termination of installation service. This board is not meant for MTP revision, because there is no such order to form state board and then district board. It should be done.
Yes.
Like permission and all, that board is there, but this board should be empowered to see the revised MTP. This board is not empowered by state board, but this should be done.
Yes, sir. It is. It's a very new guideline. It's a process will take time. It will require more than 6 months to 1 year time to become all the process has been streamlined. It needs time. Or in every state, it is just the process has been just started now. So we have to be wait for the final guidelines also.
I think.
Okay, what about
Thank you.
Any questions?
Any questions or anything to any of the speakers?
Has the presentations, I think society president and secretary have the presentations. Can you get it for the medical colleges, this presentation?
Yeah, we have it. We have with us.
Please send it to me to my mail if you can, so that I can teach my postgraduate students, because it is important. Because they are.
We have organized it. We have circulated among all this.
Yeah.
Actually,